Okay, hello everyone. Welcome to our presentation about the carpal tunnel. We are Carpal, and my name is Hank, and I will introduce our members here. So, my name is Phạm Hồng Tây in full name. Next is Nguyễn Minh Đức, Đinh Tấn Quyền Thi, Trần Gia Huy, Bùi Mai Thị Tiên, Nguyễn Thảo Chi, Nguyễn Lâm Di, and Trần Thanh Tuấn Anh. And there's a Okay, we'll take a look at the index in this presentation. We will talk about the first thing is the anatomical structure of the carpal tunnel, and the second is the carpal tunnel syndrome, which is very common in our country. Talk about symptoms, causes, and diagnosis. The second is treatment and prevention. Now we will move to the first section of this presentation, which is the anatomical structure, will present by Nguyễn Minh Đức. Thank you.
Good morning, professors. Good morning, everybody. Today, my name is Nguyễn Minh Đức, and today I have a presentation about the carpal tunnel, the anatomical structure of the carpal tunnel. First of all, by definition, the carpal tunnel is a narrow passageway while on the anterior portion of the wrist is served as an entrance to the palm for several tendons and the median nerve. Here you can see the borders, the contents of the carpal tunnels. You can see here, this is the carpal tunnels, and this tunnels is formed by two layers. The first layer you can see here is the carpal arch. This arch is formed by the linkage of the ligament of the wrist region and the 8 carpal bones. The roof of these tunnels we can see here because this is the flexor retinaculum. This is the fibrous connective tissues branch. First, we go to the first part, the deep palmar arch. The deep palmar arch. The deep palmar arch consists of 8 carpal bones, the ligaments of the wrist regions, and you can see here this is concave on the palmar side and convex in the dorsal sides. Anatomically, we can consider that these 8 bones, the carpal bones, is arranged in 2 rows of 4 bones. Lateral to medial, we have the proximal row, we have scaphoid, lunate, triquetrum, and pisiforms. The distal row, we have trapezium, trapezius, capitate, and hamate. But actually, it is anatomically. In fact, in the biomechanically and clinically, we can consider these 8 bones in 3 columns. The first column is called the radial scaphoid column, consists of scaphoid, trapezium, and trapezium. The lunate column, the second column is lunate column, consists of lunate and capitate. The third column is ulnar and triquetral column. It consists of the triquetrums and the hamate. In this we miss the pisiformis, and the pisiformis is considered as a sesamoid bones embed in the tendons of flexor carpi malis. Here you can see the base, the floor of the tunnel. It consists of the carpal bones here, and it's the ligament of the wrist region. The first, we, the first, we can divide these ligaments into three groups. First of all, we have the ulnar-carpal articulations ligaments and the radial carpal articulation ligament. We have the first ligament is the ulnar collateral ligament here. It's attracted from the styloid process of the ulnar to the carpal bones. And the same, the radial collateral ligament is the same from the styloid process of the radius to the carpal bones. The third ligament here we have the palmar radial carpal ligament. It is a broad membranous to the end of radius. Here, you see here, to the carpal bones, and to the scaphoid, lunate, triquetrum, and capitate. The fourth ligament here we have the palmar ulnar carpal ligament. It consists of three ligaments. In fact, we have the ulnar lunate ligament, ulnar capitate, and ulnar triquetrum. The name is from the ulnar to the carpal bones with the name of the carpal bone inside the Latin name of these ligaments. The second layer, the second part of the ligament of the floor, you can see over here. It is the intercarpal articulation ligament. We can name some ligament here is radiate carpals, the palmar intercarpals, interosseous intercarpals, and the important here we can see the piso-hamate ligament. It is the ligament attract from the pisiform to the hook of the hamate. The third part of this region, you can see the carpal-metacarpal articulation ligament. It consists of piso-metacarpals from the pisiform to the metacarpal bones. The palmar carpal-metacarpals ligament is from the carpal bones here to the metacarpal bones. You can see here is the floor of the carpal tunnel. This is the retinaculum, and this is the bones of the carpal bones. You can see the content of it. This is the median nerve, the flexor digitorum superficialis tendons, flexor digitorum profundus tendons, and the flexor pollicis longus tendons. You can see here it is the medial wall of the tunnels. The medial wall of the tunnels is formed by the hook of hamate, the pisiforms, and the piso-hamate ligament. The lateral wall is formed by the tubercle of the scaphoids and trapezium. Here you can see the arrangement of the carpal bones to form the concave structure here, and the retinaculum will be covered here to form the carpal tunnels. Okay, now we talk about the content. The content of the carpal tunnels. The first content of the carpal tunnels is median nerve. The origins of the median nerve is from the brachial plexus. And in the great regions is passed under the flexor retinaculum and anterior to the tendons of the flexor digitorum superficialis and the profundus. And you can see median. Okay. When it passes through the carpal tunnels, the median nerve gives 3 branches. The recurrent branch supply for the tunnel muscles, the opponent pollicis, abductor pollicis brevis, and the superficial part of the flexor pollicis brevis. The digital cutaneous nerve is supplied for. The digital cutaneous nerve consists of the common palmar digital branch and the proper palmar digital branch. It's supplied for lateral 3.5 digit and then bad nail, tip of fingers. The third branch derived from the medial nerve, you can see the motor innervation of the first and second lumbricalis. And you can see here, it is the palmar cutaneous nerve. It's a palmar cutaneous nerve. The branch of the median nerve is not go through the tunnel. It's not go through the tunnel. It go more superficial than the flexor retinaculum. It's not go through the tunnel. So here you can see that the other component of these carpal tunnels, it is the tendons. The tendons of the flexor tendons. The flexor tendons, we have 8 flexor tendons, 4 tendons for the flexor digitorum profundus and 4 tendons for the flexor digitorum superficialis. And these tendons is stored in the same synovial sheath here. And the 9 tendons here, we can see it is the flexor pollicis longus over here. This is the median nerve. And the tendon of the flexor pollicis longus, it has its own synovial sheath. We have the overview here. This is the carpal tunnel. They remove the retinaculum, and you can see the tendons, the median nerve here. This is the ulnar arteries. It's not go through the ulnar arteries, the ulnar nerve, and the ulnar vessels, and the ulnar nerve does not go through the carpal tunnels. It goes through the other tunnels. It's called the William tunnels or ulnar tunnels. Okay, my speech is finished. Thank you for your listening.
Okay, thank you, Wimede, for the analytical structure. So, my name is, you already know that. I will continue the presentation with the second section, that is the carpal tunnel syndrome. As you can see in this picture, this is a patient that has this syndrome. You can see the muscle is shrink up. That is the very like, no. That looks like, I'm sorry. This is string muscles that you can diagnose the carpal tunnel syndrome by looking the outside. Okay, so the symptoms of this syndrome is that you have numbness or pins and needles feeling in your fingers right here. Pain or numbness that is worse at night that you can't sleep. Burning or tingling in your thumb, your index, your middle fingers, and all pain that moves up your arm from your elbow. You have hand weaknesses, which means you have difficulty gripping and handling small objects. You even have difficulty making a fist like this, and you even feeling swollen in your fingers. Okay, so because of the anatomical structure that Wimede has presented us, you know that the median nerve is control of the 3.5 fingers right here. So that's why if the median nerve is compressed, inside of the carpal tunnel, you will have like lose control, like lose your feelings in these 3.5 fingers right here. Okay. As you can see, right here, this is where the median nerve is compressed, so that the 3.5 fingers, that the median nerve control, 3 fingers right here will be affected, and this will cause numbness and even cause pain in 3.5 fingers. The reasons why the median nerve is compressed is by overworking with your hands and wrists. You have a wrong posture of using the keyboard or using the computer. Okay, in the prevention and treatment, we will talk about that clearly. Okay, so this is the causes. The causes is that result from any lesion that significantly reduce the size of the carpal tunnel or increase some of its structures, which means not only the compressed median nerve that can cause the carpal tunnel structure, but increase the other structures that can cause this symptom too. So when the median nerve is affected, it will cause paresthesia, which means numbs and pin or needles in the fingers. Hypoesthesia, which means that you have difficulty in handling small objects, and anesthesia, which means you have feeling like burning in your fingers. Okay, I want you to notice this. The palmar calcaneus branch in the median nerve does not pass through the tunnel, which means even you have numbs and pins and needles in your fingers, but you can still feel anything that you touch. Okay, so we'll talk about the diagnosis. There are many ways to diagnose you have this syndrome, but I just talked about the physical examination here. So we have the Turner sign test. These tests are used to diagnose if you have the carpal tunnel syndrome. The Turner sign test is that your doctors will tap inside of your wrist over the median nerve, right here. If you feel tingling, numbness, pins and needles, or an electrical shock sensation in your hands when tapped on this position right here, you may have the carpal tunnel syndrome. That is the position right here. Okay. Next is the balance sign test. You hold your hands in front of you like this, then flex your wrist. Okay. Let your hands down for about like a minute. If you have feeling tingling, numbness, or pain in the fingers within 60 seconds, you may have carpal tunnel syndrome. So how do we treat this syndrome and prevention? I will leave it to Kate to talk about this. Thank you.
Okay, thank you for introducing me. Good morning, everyone. My name is Al. My name is Lee. Now I will continue with the carpal tunnel syndrome treatment and prevention. Okay, treatment for the carpal tunnel syndrome is based on the seriousness of the condition, whether there is any nerve damage or whether other treatment hasn't helped. There are 4 treatment options for the patient to choose from. First of all, there is the home treatment. The home treatment, such as changing the habits or avoiding some activities that may be causing symptoms. And if your symptoms are mild, 1 to 2 weeks of home treatment are likely to relieve your symptoms. And it is necessary for the patient to wear a wrist splint. What is a wrist splint? On the top left of the slide, you have the wrist splint. There you go. The wrist splint probably most effective when it is used in 3 months of the onset of the symptoms. So it is helpful to the reason it is helpful to use for the short-term treatment. Because of the long-term treatment, it can cause your muscle to be weakened, to be weak. The second treatment is the physical therapy. The physical therapy, the therapies may be done by the occupational therapists in some clinics, and the physical therapy including range of motion exercises. Range of motion is how far you can move your muscle in different directions. These exercises will help you move each joint through its full range of motion. Therefore, it keeps your muscle strong but flexible. It reduces the pain and improves the balance of the joint. The third treatment is medicine. Nowadays we use NSAID to relieve pain and reduce inflammation. Before NSAID, we have oral corticosteroid or corticosteroid injection into the carpal tunnel. But however, the corticosteroid used have numerous side effects, such as high blood pressure, water retention, and adrenal insufficiency. Therefore, nowadays we use NSAID instead. Oh, NSAID, by the way, NSAID is non-corticosteroid, anti-inflammation drug. Therefore, it's more helpful. Last but definitely not least, treatment option is surgery. If you have had carpal tunnel symptoms for a long time, like for several weeks to several months, or if there is a nerve damage or risk of nerve damage, the surgery is the ultimate choice. When other treatment hasn't helped, the surgery is recommended. The most common surgeries is for relieving carpal tunnel symptoms involve cutting the transverse carpal ligament. This one, the transverse carpal ligament, to relieve the median nerve in the wrist. And this surgery is a microsurgery because of 3 reasons. First, if you're in good hand, the incision is really small. It's just about 1 to 2 centimeters length. Second, it's a really quick surgery because it only takes 15 to 30 minutes. And last, it's microsurgery because it's just needs local anesthesia. Now I will move on to prevention. First of all, you should do physical exercises. There's some posture that you can do with your hand and wrist, like the straight, the hook, the fist, the tabletop, and the straight fist. And there are some posture that you can do with your joints, like dip joint and hip joint. The second thing you should do to prevent carpal tunnel syndrome is to maintain proper posture, especially for people who have to deal with paperwork. They have to type all day, typing, keying all day, and the best posture for keying is to keep your wrist neutral. Your wrist should not bend to tilt your hand, up or down, out to the side. And last but not least, go to the doctor if you are experiencing pain in your wrist. Okay, this is the end of our presentation. Thank you for listening.